Good evening, ladies and gentlemen. Welcome to webinar on ECG Basic and Beyond. This is the 22nd lecture, and today's topic is case studies on ECG. We have got two speakers today, Dr. Khaled Mohsin, who is the Associate Professor and Senior Consultant in National Heart Foundation, and Dr. Kaniz Fatema, who is working as Associate Professor of Critical Care Medicine, BIRDEM, Dhaka. As usual, we have got our key persons, Professor Atahar sir, Professor Abdul Wadud Chowdhury sir, and our teachers, Rafiq Ahmed sir and Professor Chowdhury Hafizullah Hassan. At the beginning of this session, may I request Professor Atahar sir to say a few words about today's session. Atahar sir, please.
Thank you very much, Dr. Firoz, and good evening, dear participants. Actually, we are very much delighted to have two lectures from Dr. Khaled Mohsin and Dr. Kaniz Fatema. And first of all, I like to welcome our faculties, respectable faculties, Dr. Rafiq Ahmed sir from USA and Dr. Chowdhury Hafizullah Hassan Chowdhury from the USA, and also we have got Dr. Urun Maski and some other panelists, Dr. Govindopal also. First of all, I want to introduce Dr. Khaled Mohsin. Dr. Khaled Mohsin is one of the talented academic interventional cardiologist in Bangladesh. He is well known. Actually, his teaching career started as Registrar of Cardiology in NICVD, and at that time we were his student. He has got very colorful, bright academic career. He is a gold medalist, and he has got his MRCP and MSc from UK. He is very methodical, very popular teacher, and very fine interventional cardiologist. He is now working as interventional cardiologist, that is the Associate Professor of Cardiology in National Heart Foundation, Dhaka. He also works in National Heart Foundation in Sylhet. So he is Dr. Khaled Mohsin. And after Khaled Mohsin, we have got another very genius, sincere, academic, and devoted cardiologist, and that is the intensive care specialist, Dr. Kaniz Fatema. We are proud of Dr. Kaniz Fatema because of his very academic devotion. She works as the Associate Professor of Critical Care Medicine in BIRDEM. He is also a executive of the Society of the Critical Care Medicine. So after Khaled Mohsin, we will welcome Dr. Kaniz Fatema, and these two lectures, that is the Dr. Khaled Mohsin and Kaniz Fatema, thereafter we have got, as before, Dr. Rafiq Ahmed sir, and followed by the Dr. Chowdhury Hafizullah Hassan. So first of all, Dr. Firoz, I like to invite Dr. Khaled Mohsin. Dr. Khaled Mohsin, please.
Dr. Khaled Mohsin sir, please share your screen. And
thank you. Thank you, Atahar bhai, for your very kind introduction and very elaborate introduction, actually. Thank you, Dr. Jamil. I think he's probably here. The course directors, the faculties from home and abroad, I welcome you all to the first presentation. I like to share my screen. Sorry. Can you see my screen, please?
Yes, we can see your screen.
Okay.
Go for slideshow.
Okay. Actually, the title of my presentation is a young lady with recurrent syncope. Actually, young lady with syncope is not a very rare entity. On a hot summer afternoon, if we visit the non-air conditioned shopping complexes of our country like the Gaussia market, we saw many ladies having syncope in a hot summer afternoon. But recurrent syncope is something very rare in young ladies, actually. So let's explore the situation. Our patient, Mrs. A 34 years old mother of an autistic child from Dhaka, attended the emergency room with 2 episodes of near loss of consciousness First of all, first episode occurred in the morning after awakening from the sleep, and the second one 30 minutes prior to arrival at the hospital. On both occasions, there were spontaneous recovery. There was no previous premonitory symptoms, and there was no convulsion as testified by her husband, and the post-recovery problem was not significant. Regarding the past history, she had gestational diabetes mellitus during her only pregnancy so far. As regards her family history, her father died suddenly around the age of 40 years before he could avail any medical attention. Her physical examination was unremarkable, and the emergency physician of the hospital, he spotted some abnormality in the ECG and persuaded her to get admitted to the CCU. And the initial impression was some acute coronary syndrome. And subsequently, after admission, she was investigated in a meticulous way, and the initial investigation in the form of hematological, biochemical investigation with cardiac enzymes, echocardiogram, and radiological examinations were all remarkable, except for the ECG. So actually, to evaluate the syncope, we advised her to undergo a Holter monitoring. We started the Holter in the morning, and at 10 a.m., that is the starting 1 hour starting Holter monitor, again developed some arrhythmia with near syncope, and she was cardioverted medically with some amiodarone bolus, and 1 hour later she again was having a similar episode that was also cardioverted medically. So she was diagnosed as a case of arrhythmia induced with an uncommon. Anisul Awal, please mute your phone. So she was diagnosed as a case of arrhythmia-induced recurrent syncope with an uncommon substrate, and she was treated medically, and she was advised to undergo ICD implantation during the same admission, and she complied and she underwent that ICD implantation. But after 1 year of ICD implantation, she was lost to follow-up. Possibly she migrated outside the country, possibly in USA, and maybe Profik sir may have encountered her in a later. Let's check the admission ECG first. This is the admission ECG, and I would like to draw your attention to the chest lead. You can see particularly the V2, there is some ST elevation with a coving pattern and T inversion. And with this ECG, the emergency physician suspected some acute coronary syndrome. And in the next ECG, it was taken from the monitor that there was a sinus rhythm and followed by a polymorphic ventricular tachycardia. So this is the cause possibly of the syncope, and this is the Holter monitor report, which showed that significant episodes of ventricular tachycardia. It's the sustained ventricular tachycardia. So let us recapitulate the causes of syncope. As defined conventionally, it is a transient loss of consciousness and postural tone due to acute cerebral hypoperfusion. The commonest cause is vasovagal or neurocardiogenic syncope. These are two types, the vasodilatory and cardioinhibitory type, and these are commonly occurring in unpleasant circumstances like hot, humid environment, prolonged standing, as well as some other precipitatory factors like pain, trauma, bad news, and something like that. The cardiogenic syncope are broadly classified into two types. That's the obstructive causes and arrhythmogenic causes. Obstructive causes, common ones are atrial aortic stenosis, hypertrophic obstructive cardiomyopathy, mitral stenosis, pulmonary embolism, tetralogy of Fallot, cardiac tamponade, LA myxoma. Arrhythmogenic causes are tachy and bradyarrhythmia. The tachyarrhythmia includes ventricular tachycardia. The bradyarrhythmia includes sinus node disease, high degree AV block. The less common ones are Brugada and long QT syndrome. As our patient has she falls into a category of uncommon cause of syncope. We will discuss later on. There are some situational syncope, includes hypersensitive carotid sinus, cuff syncope, micturition, defecation syncope. As this lady has got this type of ST T changes, this falls into the category type 1 Brugada syndrome. There are other types as well. These are the saddleback pattern, and there is some intermediate types. So whatever it is, let's recapitulate some background. That in 1992, the two Spanish brothers, Pedro and Joseph, they first described the disease entity. There is right ventricular conduction delay. There is dynamic or persistent ST elevations in the right precordial lead. And statistically, it's shown that the 12% of sudden cardiac death in young adults without structural heart disease, Brugada is the underlying cause. Males are affected as much as 4 times than females. The global prevalence is 0.05%. It's higher in China, and in Southeast Asia, the prevalence is about 0.1%. But in some cases, the ECG changes are not always obvious, and then they needs to be provocated by some challenge, pharmacological challenge. The risk of VTVF, once there is a single episode, there is a recurrence risk of about 50% in next 5 years, and the vulnerable period of life is 3rd to 5th decades, but it can occur at any time. And symptoms may be non-specific, like palpitation, dizziness, to recurrent syncope, nocturnal agonal respiration, and aborted sudden cardiac death. Ventricular fibrillation, it is usually occurs at night or at period of increased vagal tone, and it may be initiated by ventricular extrasystole originating from right ventricular outflow tract. Supraventricular arrhythmia is also found in about 15 to 30% of the cases. As I already shown that there are 3 common patterns, but the type 1 has got diagnostic and prognostic predictive value. These are the drugs which are used for pharmacological challenge. Among those, ajmalin, the sodium channel blocker, it is very used as a provocative agent. There are other agents as well. Flecainide and procainamide are antiarrhythmic drugs, but they are used as provocative agent. Here there is a patient with incomplete right bundle branch block, and the ajmalin infusion has been started, and as the dose becomes incremental, we see there is characteristic pattern is emerging at a higher dose. So it is a provocative test. There are some non-specific causes with Brugada-like phenotype, which we need to keep in mind. That those are acute coronary syndrome, pericarditis and myocarditis, pulmonary embolism, some metabolic disorders and electrolyte disturbance, aortic dissection, thiamine deficiency, post-cardioversion, electrical cardioversion. left ventricular hypertrophy, right bundle branch block, asymmetric septal hypertrophy, and arrhythmogenic right ventricular dysplasia. Pathophysiology, the site of origin is particularly the right ventricular outflow tract. There is reduced conduction velocity, the reduced gap junction expression, there is fibrosis and disturbed depolarization. It is a particular disease affecting the sodium channels. The depolarization hypothesis, it predicts that there is imbalance between depolarizing inward and outward channel during repolarization in the right ventricular outflow tract. There is a scoring system which is known as the Shanghai score of Brugada diagnosis. There are some ECG changes like spontaneous type 1 changes which carries very high significance, the fever induced change, similar change, or the drug induced change, but it is not that much predictive value. There are the background history, the cardiac arrest with or documented VT and polymorphic VT on VF, suspected arrhythmogenic syncope unclear etiology, these are lower predictive value. The family history, the first degree relative having similar symptoms. If there is more than 3.5 points, it is a probably high predictive value, 2 to 3 point possible, and less than 2 points, it is non-diagnostic. This is the Shanghai score. The pattern of inheritance is mainly autosomal dominant. There is different type of genetic mutation has been found, which is present in 20 to 30% of the patients. Molecular genetic testing is presently indicated, which in a type 1 patient with type 1 ECG is a class 2A indication. The patients are definitely at type 1 ECG with unprovoked ECG. They are at high risk of sudden cardiac death, and they benefit from implantable cardiac filter defibrillator. And the spontaneous type 1 ECG holders have a high risk of ventricular tachycardia and ventricular fibrillation. There are some issues of risk stratification. The non-arrhythmogenic syncope are also seen in Brugada patient, which has got no prognostic implication. The asymptomatic patient also have very low incidence of malignant arrhythmia. That's less than 0.5% per year. VTVF induction in a previously asymptomatic Brugada patient is associated with higher risk of ventricular arrhythmia in future. There is some novel risk marker, the fragmentation of QRS complex. It is quite significant. We are seeing that the QRS complex is fragmented. This predicts higher risk of arrhythmia and sudden cardiac death. This is the fragmentation and after depolarization type of changes seen in the ECG. How we treat the patient? There are some medical treatment, but we have to understand that the class 1C antiarrhythmic has proarrhythmic effect and should be avoided. Antihistamine, cocaine, alcohol should be avoided as well. And drug therapy, it has got a role in electrical storm, like 3 or more VTVF in 24 hours. And in this group of patients, isoprenaline and quinidine are used as class 2 recommended medication. The fever can also induce ECG change as well as arrhythmia, and hypokalemia is a definitive risk factor. Quinidine can be considered in asymptomatic patients as well with type 1 ECG. This is a class 2B indication. There are some other drugs. I don't think they have got a very strong clinical indication like beperidil, azacetine, These are they inhibits the transient outward current and cause upregulation of the sodium channel. This has got some beneficial effect. These are the two drugs which has got some clinical implication or benefit, like isoprenaline or orsiprenalin. They can be used in conjunction with quinidine, and they have the potential to suppress VF and VT and normalize the ST elevation. And cilostazol is a phosphodiesterase 3 inhibitor. They also tend to normalize the ST segment elevation by augmenting the calcium current and reduction of transient outward current and increased cyclic GMP and inhibition of adenosine uptake. These are the two medications which has got clinical implication. ICD is the mainstay of treatment in Brugada syndrome patient who have survived a cardiac arrest or documented VT with or without syncope, and it is a class 1 indication. And ICD is also indicated in patients with symptomatic Brugada patient with arrhythmic syncope and a spontaneous type 1 ECG. And it has shown to be effective in preventing sudden cardiac death. And in patients with drug-induced changes with a positive family history of sudden cardiac death, but they don't have a documented arrhythmia, in those patients ICD implantation is currently not recommended. And ICD is not free from problems because inappropriate shock over 10 years is about 37% and lead failure is about 29%. So we have to be very choosy in advising ICD in Brugada patients. And in cases of electrical storm or repeated ICD shock, we need to, the patient should be offered catheter ablation as well. This is a summary of the management options. If the patient is symptomatic with survivor of cardiac arrest or sustained VT, the ICD is a class 1 indication. And electrical storm, the isoprenaline plus quinidine followed by ICD implantation. And inappropriate shock, we can prescribe quinidine, cilostazol, and the definitive therapy is RVOT ablation. And nocturnal agonal rhythm, it is also a risk factor. The syncope, seizure, if we consider them to be arrhythmogenic origin, ICD can be given, but it's a class 2A indication. And they can be followed up as well with or without an implantable loop recorder. And the spontaneous and fever-induced Brugada patients, so they are, if they have an inducible arrhythmia, they can be prescribed ICD, and there is non-inducible arrhythmia, they should be followed up, and they can be prescribed quinidine therapy as well. So these are the management option. And the Brugada induced by sodium channel blocker, they should be followed up periodically, but ICD is not shown to be beneficial. So what are the take-home message? Brugada syndrome is an important differential diagnosis in syncope and sudden cardiac death in young adults without structural heart disease. Brugada syndrome is diagnosed in patients in a spontaneous way, or they can be provoked by some drugs, sodium channel blocker, in the right precordial leads. The symptomatic patient with type 1 ECG plus arrhythmic syncope, they are the very high risk of sudden cardiac death and should be offered an ICD implantation. The risk markers, the fragmented QRS complex, they also predict future cardiac event. And there are some electrophysiological measures like the electroanatomic mapping techniques in the right ventricular outflow tract. Catheter ablation can prevent recurrence of VT in highly symptomatic patients where the other treatment options have been exhausted. So thank you very much for your patient hearing, and I think we can stop sharing the.
You want to show your second ECG also?
No, this is the first one ECG 12 lead, and another one is the monitoring.
No. You have got two cases, right?
No, one case. Only one.
Just one case. This is the only case you have.
Yeah.
So we can go for discussion for a short time. May I request Rafiq Ahmed sir to discuss a few words about the case or regarding Brugada syndrome or the ECG presentation. Rafiq sir, are you with us?
Yeah. No, I think this is a well presented case. I mean, this case shows everything, and the patient was very lucky that it was diagnosed before she died. So I think keeping a high degree of suspicion. Interesting that Brugada is more common in Bangladesh than in the United States. We see much less of it. But as Khaled Mohsin mentioned, that not all Brugada ECG findings should be aggressively treated with ICDs. So risk stratification is important. One other factor that you will see, like I saw a patient who had no syncope, came to hospital with flu-like symptom and low-grade fever, and had ECG Brugada pattern. So now this patient also complained of some dizziness. So what did you do? We did an echo, which was normal. No family history of sudden death. And then when the fever resolved, the EKG change resolved. So please remember that Brugada pattern ECG in genetically predisposed people can be precipitated by various factors, including low-grade fever. Those patients don't need ICDs. They should be, but the careful family screening is very, very important in those patients. So please keep that in mind. So good case, Khaled Mohsin. Thank you.
Khaled Mohsin. Hello, Khaled Mohsin, bhai.
Please.
Actually, no, your excellent presentation, that is excellent presentation regarding the Brugada syndrome, and nice demonstration about the resting ECG followed by the documented that is a polymorphic VT. So what are the advices you offer to the patient's family member? Did you have any?
Actually, she had only one child. She was a autistic child, and she was the only child of her parents. And her father died about the age of 40 years, suddenly, unexplained death. So we think that his father might have been one of the fatalities of the same problem, but we couldn't document it. And regarding the family screening, we didn't find any very close relative except her child. So we advised her to take her child to an electrophysiologist for screening in future. But she was, as the child was autistic, she was attending the Shishu Hospital, the child development program. They have a Shishu Bikash Kendra in Dhaka Shishu Hospital, and there we suggested the pediatricians and the pediatric neurologist to refer her to an electrophysiologist. And at that time, I think probably, but unfortunately the patient is lost to follow-up because she migrated outside the country. So I don't have any further information regarding the well-being of the patient as well as her only daughter.
There is a recommendation for genetic testing. What extra information does it give to us?
Actually, the genetic testing, in the high-risk patient, there is 30%, I have already shown the statistics. The genetic test, it is a autosomal dominant disease with a variable penetration. And in case of 30% cases, we can see, we can find a genetic abnormality. So I think there is a very significant chance of vertical transmission to the next generation actually, because the previous generation we could not identify. So I think the child should be offered a genetic testing. There's no doubt about it.
Khaled bhai, can I ask you a question?
Yes, please.
I have seen one doctor, that doctor and his sister, both of them have typical Brugada type A pattern, but no history of syncope, no history of arrhythmia or anything.
Yes.
Structurally, otherwise normal heart.
Yeah.
And what should we do regarding such cases?
Actually, in a type A Brugada syndrome patient who are asymptomatic, so in this group of patient, ICD, there is no documented evidence of arrhythmia, but they should be followed up very meticulously. As Rafiq sir has said, I think Atahar bhai, would you like to comment to Wadud's question regarding asymptomatic patient with type A?
Yeah, both brother and sister have similar pattern.
Yeah.
Brugada type ECG, type A.
But totally asymptomatic, and there is no negative family history, Wadud bhai.
No. Simply.
That is negative family history for the sudden death. There is no history of the sudden death in the family. Only the Brugada type, yes. This is the actually final recommendation, actually what is stated by Dr. Khaled Mohsin bhai, that is, they are not should be treated aggressively. But if the type is type 1, if the type is type 1, definitely they have got the high risk for the sudden cardiac death. But type 2 and type 3, they should not be treated aggressively. And actually there is recommendation for the EP study for the Brugada syndrome for re-stratification, but unfortunately this is not practiced. I think I want to ask to Rafiq sir, but it is not practiced nowhere. That is the, sir?
Well, the EP and the medication, these are very controversial because the arrhythmia is polymorphic. I can induce polymorphic VT in anybody I want to. And the electrophysiology study induction of polymorphic VT is the non-specific finding. So electrophysiology study is not very good. The question is prevention of sudden death. I mean, Khaled Mohsin mentioned multiple medications. I cannot leave a patient just with medication. And if they have, because without defibrillator, mortality is 100% in this group of patients. Medication will be useful. If somebody has ICD, I want to reduce the number of shocks. Likewise, electrophysiology study, we don't routinely use it. I mean, it is very controversial. I think rather the family history, detailed family history, risk of sudden death, those are the very, very important points to determine. And a careful history, like this patient had father died. I'm sure he had Brugada syndrome, that he died suddenly.
But sir, what is Wadud's question? That is the asymptomatic type 1 Brugada, brother and sister. But there is no symptom and the family, there is no history of the sudden cardiac death in the family.
We don't study those patients. We keep a note of that. And if there is no family history of sudden death, we cannot study. We do not know. I mean, I think what will happen in the field of genetics, a lot of development is going on. And if you go back like 10 years, we had no clue about these things. So I think the genetic studies are going to be more and more, and we'll probably be able to identify much higher risk and correlating them with the genetic pattern. Because even the EKG change is single EKG change, there can be multiple genes and gene location involved in this process. So right now, if no family history of sudden death, I'm going to just follow the patient carefully.
Rafiq sir, is there any role of an implantable loop recorder in the asymptomatic patients?
Again, I mean, if the patient has EKG finding only, no history of syncope, pre-syncope, no family history of sudden death, how long am I going to monitor this patient? On the other hand, what I did, that my patient gave some history of dizziness. I gave him cardiac monitor for 4 weeks. That's about it. And I offered him a loop recorder that, look, you can have it, but patient decided not to have the loop recorder put in. If there is history of syncope, then of course that becomes a different story. And I have doubt about that this can be, somebody with Brugada can have vasovagal syncope also. And if I think that there is a question, there is a difference in the history, then I can put a loop recorder. Otherwise, I don't think it's of much value. Except for one patient, I saw one patient who had, this is not Brugada. This is a patient with hypertrophic cardiomyopathy, septum of 15 millimeter. And I put a loop recorder in because she was having palpitation. And one night she had an episode of self-terminating ventricular fibrillation. But that's an unusual case. We don't routinely do those things. It was just, she is a lucky patient that she had a loop recorder in place when she had this arrhythmia. Thank you.
A patient who has multiple ischemic cardiac risk factors like hypertension, left ventricular hypertrophy, diabetes, and the ECG shows it almost looks like a Brugada, but arrhythmia. Is there any study that suggests the presence of this ischemic substrate also increases the chance of sudden death in this group of patients?
Not that I'm aware of, but I will cath those patients. I mean, if patients with Brugada kind of ECG around the age of 50, 55, hypertension, diabetes, we routinely cath them, do cardiac catheterization, just to make sure that I am not missing a substrate that can contribute to this problem.
And sir, another is that for ischemic heart disease, our preferred drug is, as always, beta blocker. But in Brugada, the chances of arrhythmia is mostly at night when the vagal tone is high and the heart rate is low. And what is your face like that?
It brings us to the question of beta blocker. Do you mind? I'm on call, so I have a phone call. I have to answer that, and I'm going to come back in a second.
Okay, sir. Sir, Khaled bhai, do you have any answer to that?
Actually, it is shown that the beta blockers and amiodarone are largely ineffective in case of Brugada syndrome, and rather the isoprenaline, it is the sympathomimetic drug. It is a beneficial actually. Beta blocker does the opposite actually. So the isoprenaline in combination with quinidine, it's a preferred option. And another one is the phosphodiesterase inhibitor, cilostazol. These are the three medications which are currently being prescribed, but with some variable success. Mostly they are used for the combating or the electrical storm after ICD implantation. So ICD is the mainstay of treatment, and following ICD implantation, if the patient experiences some untoward the DC shocks or inappropriate shocks, I think can be about maybe more than 1/3 of the patient, like the 37% patient experience inappropriate shock over a period of 10 years. So it is quite high, and the patients become very prone to anxiety, and their quality of life deteriorates if they receive inappropriate shocks. So in this group of patients, isoprenaline with quinidine combination therapy is quite indicated. Dr. Jamil, would you like to say something about it?
No, I agree with you. Thank you.
Thank you, sir. I think all these drugs are in class 2B indication. For the fellows, you have to remember that these drugs are class 2B indication. As Khaled Mohsin sir said, the class 1 indication is ICT. I think we can shift to our second lecture by Dr. Kaniz Fatema.
May I ask a question?
Associate Professor of Critical Care Medicine, BIRDEM. Please go for your presentation. You can share your screen. Professor Jalal sir, we'll discuss it later on, probably after Kaniz Fatema.
Right. Asatuzzaman, you please just, Asatuzzaman had a question just after this.
Yes, sir.
Thank you, Firoz Bhai. My respected senior teachers and my dear colleagues, Assalamu alaikum. I'm Dr. Kaniz Fatema, Associate Professor from the Department of Critical Care Medicine, BIRDEM Hospital. Now going to present today's my presentation, that is on case studies on ECG. I am grateful to Professor Atahar sir for his kind words, and grateful to Wadud sir and Atahar sir to encourage me to present in today's session, because I'm not a cardiologist, I'm an intensivist. So actually I was very nervous to present today. And today I have prepared my presentation slightly differently. There is no theoretical discussion because I think most of the participants here are cardiologists, and all of you know much more than me as cardiologists. I'm mainly focused on presenting the ECGs. About those, we have some confusion and some queries. To mainly, I want to share my experience and learn from my seniors and the cardiologists. I work in Bangladesh Institute of Research and Rehabilitation in Diabetes, Endocrine and Metabolic Disorder, that is BIRDEM Hospital. This is my department. This is before the COVID period. Besides BIRDEM Hospital, I am also involved with 2 other private hospitals. It is something like GP. Unfortunately, none of these 3 hospitals, we have facility for intervention cardiology. That is, we cannot do primary PCI or temporary pacemaker or angiogram. So most of the time we get patient with other problems. Very, very rarely we get patients with primary cardiac problems. This is the picture now in COVID era, and the cases which I'm going to show. All these cases are collected like from October and month of November, that is between this COVID period. My first case, 70-year-old hypertensive male. He was a known patient of CKD, stage 4. His baseline creatinine was between 4 to 5, and he did test it at the last November. And after that, as the pandemic started, so he did not visit any physician from the month of March. He was admitted in a local private clinic with the complaints of scanty micturition and general swelling for 7 days. There, they did some baseline investigation which revealed that his hemoglobin was very low, that is 4.7, and creatinine raised to 6.7. On the day of ICU admission, he had severe respiratory distress and developed altered level of consciousness. So he was referred to ICU and brought to our ICU. On admission, his pulse was 52 and blood pressure was 100/70 millimeter of mercury. ABG showed combined acidosis and hyperkalemia. His potassium level was 7.1. This was his ECG on admission. May I request Firoz Bhai that as I have few cases, like 6 to 7 cases, and on the ECG I have some queries. So can I discuss the ECGs between the session?
Sure.
With the permission of the panelists.
That is better.
May I request Atahar
Okay.
sir to make some comments on this ECG? Atahar sir,
Thank
please.
you.
Actually, I want to hear from Kaniz. Actually, what was your diagnosis
Okay.
in this ECG?
Sir, in this ECG, we diagnosed this as idioventricular rhythm. The pulse was low, as I have mentioned. He had bradycardia, and before getting all the lab report, we assumed that this is due to hyperkalemia, which he had in his previous hospital admission. Patient, as his conscious level was down and he has low blood pressure, So we intubated the patient and put on mechanical ventilator and started noradrenaline. And after we get his blood report, his creatinine was jumped from 6 to 11. So we started hemodialysis and gradually patient's condition was improved. We started weaning the patient, but after 5 to 6 days during hemodialysis, his blood pressure suddenly fall down and monitor showed tachycardia. We did ECG and it showed atrial fibrillation. We converted the dialysis mode from hemodialysis to
Can you
SLED.
go back? Can you go back to the other
Sure,
ECG?
sir. Sure, sir.
Yeah, because that ECG we need to
First
talk.
one. This one, sir. Right.
Yes.
So we diagnosed it as idioventricular rhythm.
Yes.
Was it right?
Okay. So anybody any comment about that diagnosis of idioventricular rhythm?
Sir,
I disagree with the diagnosis.
now, whether she did consider any differential diagnosis, sir, Kaniz Fatema, did you consider any differential diagnosis for this ECG?
No, sir. We did.
Okay, let me.
Thought that this is due to hyperkalemia.
Okay, I'll make a comment on the QRS duration is about 100 milliseconds.
Yeah.
Yes, sir.
Which is normal.
Yes, sir.
So we will consider idioventricular when the QRS is wide. So this is not a wide QRS. So definitely the rhythm is a supraventricular rhythm. And the question is why we have this little bit of fast, little bit, that's a different story. So it is not a ventricular rhythm. So that diagnosis.
Maybe it's junctional rhythm.
Yes.
Sir?
What was the potassium level at that time?
Sir, at the outside hospital, it was 7.1 and in our hospital, it 7.5.
Yeah. If you look at the first few beats, they look fairly regular.
Khaled bhai, please mute your. Okay. Prof, sir, please.
Yeah. So the first few beats look regular. So as Jamal was saying, junctional rhythm, right?
Yes, sir.
Yeah. I mean, that's a possibility. Other possibility, sometimes in hyperkalemia, even if there is a P wave, we just cannot see it.
Yes, sir. Low voltage P wave, sir.
Exactly. Very low voltage P wave. I mean, it's pretty regular. It's a little faster. So it can be any of those. I mean, junctional rhythm with irregularity. Why that is irregularity, I cannot explain. But definitely, it's not atrial fibrillation because it's not irregularly irregular. So we are. I think we. Anybody else? Any comment beyond that?
Sir, what about the rhythm? The rhythm is
Is it possible? I'm Professor Jalal. Can it be sinus node dysfunction?
Yes, sir. Sinus node definitely is a possibility, but in the setting of hyperkalemia, I will not use that term because potassium is 7 and that can really distort all our findings. Sinus node dysfunction should be reserved for a situation where there is abnormality of sinus node function without any other reversible cause.
Prof, sir, may I have a comment, please?
Yes, please.
Actually, it is having a chronic kidney disease and that might lead to pericardial effusion. This is a predominantly low voltage ECG actually. Can there be any pericardial effusion as well, which is masking the amplitude of all the QRS complexes because we expect a higher peaked T waves in hyperkalemia?
Yeah, possible, definitely.
Sir,
okay, so let's look at the next
question also, sir. A patient with atrial fibrillation, if develops hyperkalemia, is there any chance that the fibrillatory waves will be disappeared, like the P wave?
But the initial part is very regular.
Sir, in case of atrial fibrillation, if the patient develops hyperkalemia, 7.5, is there any chance the fibrillatory waves also disappear like T wave?
Oh, yes, absolutely right. I mean, the question is, it's a very interesting question because if somebody had hyperkalemia and develops, atrial fibrillation develops hyperkalemia, we may not be able to see the fibrillatory wave either. And that's the point. I was looking at those first few complexes. and I measured them, they look fairly regular in the beginning part. So initially, that was my thought process was, is it atrial fibrillation? So, but I think we should still keep the diagnosis of atrial fibrillation in this case as a possibility.
Sir, then,
No question.
sir, for the working diagnosis, we will consider at the supraventricular rhythm, not the idioventricular rhythm.
No, not with, yes, exactly. It's a supraventricular rhythm, definitely.
Or junctional rhythm.
So we can call it junctional bradycardia.
Yes, maybe.
Okay.
Junctional rhythm should have a regular, regular, but it is the rhythm appears to be irregular.
It is better to say the junctional
1,
arrhythmia,
2,
not
3,
junctional
4,
rhythm.
5, 6. The first 6 beats are regular. Khalikuzaman.
Next, sir, next beats,
Next
4 or
beats are
5
irregular,
beats,
right?
irregular.
First
The
6
junctional should be regular. There is right bundle branch block as well, incomplete type.
Yes, one important thing that this patient developed atrial fibrillation in the next ECG.
Right.
Should we go to
Yes,
should I go to next slide?
Yes,
Next slide, please.
Okay. After giving dialysis, his rhythm became sinus, but after 6 to 7 days, he developed hypotension, and at that time we noticed tachycardia. And this ECG was taken at that time, which showed atrial fibrillation.
This can happen because most of these patients are hypertensive. They have got diastolic dysfunction, LA enlargement, and most of the patients, some of these patients may develop atrial fibrillation in long term.
We sent troponin I, which was marginally raised, not that much. ECG on the next morning, we started amiodarone to control this atrial fibrillation. Next morning, we did ECG, and that ECG, here we can see that there is ST elevation, but only in lead V2. Only in V2, atrial fibrillation persisted.
Now, I think we want to hear from Professor Wadud Chowdhury. Wadud bhai. V1, V2, V4 also.
Assalamualaikum.
Yes, sir.
The thing is, in the first ECG, the first 6 beats were regular. The rate was 66 beats per minute. The next 5 beats were totally irregular. Typical of atrial fibrillation. 1, 2, 3, 4, 5. The later ECGs, as Firoz has said, CKD patients are very likely, very prone to develop atrial fibrillation, particularly during dialysis when there is a change of blood pressure, very high to very low, something like that. Also during if there is an electrolyte changes. My question is, in this type of patient, in CKD patient, when the patient is on dialysis, which drug will be better suited to control the heart rate? Can we use Digoxin, which can be available widely, or do you have to use amiodarone? Rafiq sir, can you give us some insight on that?
But before that, Wadud bhai, just comment on these STT changes.
I would not comment on that because the changes are not typical only on lead 2, V2.
Sir, can I show the next ECG?
Increase.
Another one?
By increase, the
same patient.
Raised slightly in case of CKD. So that was not diagnostic. Now, the next ECG, it shows typical changes. Now, these changes suggest this could be a case of Wellens type changes.
But
is possible.
there is a significant prolongation of the QT interval as well. There is probably the patient has developed hypokalemia.
Yes.
Yeah. Probably after.
Sir, Rafiq sir, this ECG, sir, this ECG that is the showing the STD changes. Whether this patient has got the pericardial effusion right this time. Whether these STD changes can be explained with the pericardial effusion.
Yeah, I was looking at the AVR, but there was no change in there.
Sometimes hyperkalemia may induce pseudo-infarction pattern, affecting the anteroseptal leads as well, ST elevation induced by hyperkalemia. Sometimes can be confused with acute myocardial infarction. So it may confused with hyperkalemic ECG changes.
So these are the possibilities. That is hyperkalemia and the pericardial, that is the pericarditis, that is the pericardial effusion also. HTD changes. Ischemic changes is unlikely. But the Rofik sir is here.
Well, I mean, we can always go all through all these differential diagnoses. I will show you, it's a very coincidence, I have a similar patient with ECGs. We'll show those ECGs today. I mean, that's the beauty of medicine, that there is no clear-cut diagnosis. I mean, ST elevation is there. Hafiz make a comment, but we have 10 to 18 ischemia and pericarditis both. And as Jamal pointed out that earlier ECGs were low voltage, but we did not do any pericardial tapping in between. And we don't have any echo, so we cannot make that further comment on that.
But Rafiq sir, the dialysis can improve the pericardial disease as well, actually, because we know that in uremic pericarditis, dialysis is the preferred mode of treatment.
Yeah, definitely.
Dr. Kaniz, what was the echo findings of this patient?
But I think
there was no pericardial effusion.
Let me make one comment.
No pericardial effusion, and after starting dialysis, potassium level came to normal.
Yeah, for our audience and the panelists, of course, we are consultant level panelists, audience who are listening. We are not trying to confuse you. We are just presenting the reality of medicine. That means, look at here, we are multiple consultants from different countries sitting down and discussing cases, and we don't have a definite answer. And that's where in clinical medicine, we have differential diagnosis. That we look at an ECG, we think about it, and we consult each other. And I think I will encourage everybody that, look, you find an ECG, instead of saying, oh yeah, I think this is ischemia, or I think this is pericarditis, send it to a friend of yours. Yeah, hey, by the way, what do you think? We do it all the time here. And really get some input on that. Hafiz, you want to say something? Hafiz probably is offline.
First of all, these EKG changes are not indicative of like ST elevation MI. It is not. And pericarditis, hyperkalemia, we can do the dialysis indicated if needed, and then repeat the EKG. You can do an echo to see wall motion and be assured. So I would not jump on the ST elevation MI side. And the small troponin, not uncommon in dialysis patient. About digoxin, we can give, we avoid digoxin in dialysis patient, but we can give loading dose of digoxin.
Yeah.
And don't check the digoxin level. That is typical surgical resident move. You give digoxin loading dose and then check the digoxin level. It is meaningless. So we can do the loading dose of digoxin to see the control of the rate. But usually it takes longer for the digoxin compared to amiodarone.
Can you go to next?
Thank you, sir.
Okay, thank you, sir. And this was his subsequent ECG on the next day.
Sinus rhythm. Left atrial and
so what about the T-wave changes? And
yes. QT prolongation.
Consistent with hypokalemia.
At that time, what was the level of potassium at that time?
So potassium was at admission, potassium level was high, but later potassium became normal. There was no hypokalemia.
But at this type ECG, this ECG at that time,
the potassium was normal. Potassium was all through normal.
Normal, okay.
Ultimately, we could extubate the patient successfully and discontinue the inotropes and shift the patient to ward.
Was the patient getting amiodarone while this ECG was done?
Yes, sir.
Rafiq sir,
after 24 hours, we changed to oral amiodarone after giving IV amiodarone for 24 hours.
Rafiq sir and Atahar bhai, can this QT prolongation due to amiodarone?
Yeah, I mean, it can be a combination of both too. But one thing I'll be very, very careful about converting somebody because we did not know the duration of atrial fibrillation. So unless we do a transesophageal echocardiogram and simultaneously anticoagulate the patient, we should refrain from attempting to convert this patient because they can stroke out. So that's one thing that we try to avoid. Unless atrial fibrillation is hemodynamic, even in hemodynamic unstable situation, we will do a transesophageal echocardiogram to make sure there is no blood clot in the left atrium. Please keep that in mind, otherwise we'll have stroke. But I think it can be a combination of the amio with electrolyte change. I don't know what the potassium level was at that point.
So
the potassium was normal.
One good input here, hypocalcemia can lead to also QT prolongation. As the patient was on dialysis, that is a possibility. What was the level? Kaniz, can you tell us?
Sir, calcium level was normal at the beginning, but we did not check it later. We checked it only once.
Kaniz Fatema, did you shift the patient with this ECG or after normalization of the ECG?
Sir, after normalization of the ECG, because during taking this ECG, he was still on ventilator, though inotrope was stopped. But after extubation, even after extubation, he stayed in ICU for 7 days due to some lung problem, respiratory problem.
Hafiz Bhai, can you
Yeah.
ask a question? As you are a cath guy, do you want to do the cath in this patient?
So, couple of things. Amiodarone-related QT prolongation is actually least associated with the drugs. This QT prolongation is not associated with the polymorphic VT that we see, but it can happen. And the second thing is that you see that biphasic T wave in the V4, V5. I'm coming to that in a second. But one comment about the TE cardioversion. In the US, in many emergency rooms, they are doing the TE cardioversion without TE. But as Rafiq Bhai said, if you know that there is long-standing or paroxysmal, then it is better to go with the TE guided. There was a study from Canada that they looked into this, and actually it was pretty safe, but their data was 30-day stroke rate without doing TE. So that's something to think about. I would not recommend that in this patient because dialysis, left atrial enlargement, probably non-compliant LV with hypertension. So this is not an acute or risky cardioversion in this patient if you want to do that way. About the cath, this patient, this biphasic is a late in the 3-4, and there is some, I don't know, I'm not seeing very well. I suspect there may be some LVH in this patient. And in the presence of LVH, this atypical type of biphasic T wave, hard to say that this is proximal LAD disease that we worried about the Wallenstein. This is, I would not worry about. I would go by the clinical patient's symptoms, and also if the echo shows LVH, I feel reassured that we can do other way to look for ischemia if you need to. No desperation for cath. One thing important, why the patient got intubated? I was not present because I lost connection. Why the patient got intubated in the
admission,
first place?
On admission, patient had respiratory distress with, and his ABG showed combined acidosis. That is hypercapnia with metabolic acidosis. That's why
hypercapnia. Because I worry about, whether there is LV, non-compliant LV with MR opened up. So that's another important thing to think about, yeah. And accelerated hypertension, whether there was any renal artery stenosis. But looks like this is a known dialysis, so not to worry about.
Dr. Kaniz, may I ask?
Yes, sir.
This patient was severely anemic. The hemoglobin was 4.7 on
4.7.
So can there be a secondary MI due to was the anemia corrected?
Sure, sir. Sir, before giving him dialysis for the first time, we collected 2 units of RCC, and in subsequent dialysis time, he got blood transfusion, and his hemoglobin level was between 8 to 9.
I agree. This is type 2 MI, and we don't need to worry about coronary artery stenosis unless we ischemia workup. I say ischemia workup downline if needed.
Yes.
Did you repeat the troponin I later, Dr. Kaniz?
Yes, sir, but it was marginally raised, very marginally, which we expect at patient with ESRD or CKD stage 4.
Yeah.
No, difference between the first and second troponin I?
Not much significant.
Rising or
no,
same?
Not rising, almost same.
So
Should I move to the next case?
Yes.
Please.
Kaniz Fatema, excellent. But a series of ECG of a single patient and an excellent demonstration for us and for our participant. And
Next case. Yes. Beautiful.
Very nice.
Thank you, sir.
এখানে স্যার একটা কোশ্চেন হচ্ছে যে একটা পেশেন্ট যদি অ্যাট্রিয়াল ফিব্রিলেশন থেকে স্পন্টিনিয়াসলি রিভার্ট করে তাহলেও কি is there any risk of development of thromboembolic manifestation even there is spontaneous reversion without any active DC cardioversion or active pharmacological cardioversion?
There is spontaneous termination, yes. That is, it is the time of termination. There is a conversion of the AF to sinus rhythm. This time the patient develops the
at any mechanism.
So whether the question is actually what is told by the Rofik sir, what is giving the importance that whether the question is whether the patient has got the clot in the LA or not. If it is the first time, it is unlikely, but if there is a long-standing history of the paroxysmal atrial fibrillation, it is always to consider that there may be possibility that there may be clot in the LA.
Sir, I didn't show the sinus ECG here, but after starting the dialysis, patients the initial was junctional rhythm, but after starting the dialysis, his ECG turned to be in the sinus rhythm, but I didn't show it here. So when the patient developed atrial fibrillation, we gave him amiodarone.
Yeah, so just to add one point, in the case of mitral stenosis, significant mitral valve disease, it is a non-negotiable about the role of anticoagulation and the TE, because these are the highest risk group, and these are not. We talk about CAD-VAS, which is a significant mitral stenosis. These patients were actually excluded from the CAD-VAS calculation, and historically they are high risk. They were not even included in the SPAF trial or PNAF trial or the AFib trial, because it was thought inappropriate to randomize the patients with significant mitral valve disease. And also another group, hyperthyroidism group, also not included in the study.
Okay, sir, my next case, 70-year-old hypertensive male who was a current smoker, was admitted in our ICU with sudden onset of severe headache for 1 day, followed by loss of consciousness. On admission, his pulse was 100, blood pressure was 80 by 40 millimeter of mercury, saturation was 88% with 10 liter of supplemental oxygen via face mask, and he had very low GCS, that is 4. We immediately intubated the patient, put on mechanical ventilator, and started noradrenaline for his low blood pressure. This was his ECG. We can see here that is tall P in lead 2, 3, and AVF, and there is the negative P in the V1 or biphasic P in the V2, and there is sinus tachycardia. On his biochemistry report, there is neutrophilic leukocytosis. Other than that, his renal function, liver function, serum electrolytes, all were normal. We sent his troponin I, which was found to be very high because the cutoff value was 0.06 and his tropi was 1.43. So So we were confused and looked again the ECG. So sir, here is our question that his tropi was, I can see it is about more than 20 times raised because the cutoff value was 0.06. But in the ECG, there is no change other on the sinus tachycardia. So we diagnosed him as non-ST elevated myocardial infarction. But as patient has altered level of consciousness, we did CT scan of brain, and there was large hemorrhage in the cerebellar area with ventricular extension and obstructive hydrocephalus. So we could not do much for this patient. This is about the second case. So should I move to the next case?
So Wadud,
I think we need to make some comments here. So,
before going
Sure,
for
can I make some comment here?
Sure, sir.
Okay, so
yes,
the diagnosis of non-ST elevation MI, I have difficulty to accept that because the clinic acute coronary syndrome, non-ST elevation MI, there is no clinical features here to go along with that, and the troponin rise has other reasons to explain, right? So therefore, non-ST elevation MI diagnosis, you can say troponin rise, injury, etiology unclear, or you can say possible type 2, or we don't know. The reason is the patient present, this is the part I think we all need to be on the same page. And it is, it is non-negotiable. That means we cannot just sell it as non-ST elevation MI because of the troponin, regardless what is the level of the troponin, because patient clinical presentation is headache, there is nothing else, and the EKG is not suggestive of either. And you have another explanation soon, right? So
Yeah.
we should not call it non-ST elevation MI. And another important thing, when we call non-ST elevation MI,
Sir, you have muted yourself. So we cannot hear
okay,
you.
So when we talk about non-ST elevation MI, we actually mean type 1 MI. So we are committed. So when we talk about troponin, EKG changes, clinical syndrome, we should be very clear. And it is better to admit that troponin rise, etiology unclear, injury versus type 2 MI. Here, there is nothing to suggest type 1 MI. So I think we'll be careful because the therapeutic implication is huge. Somebody may start heparin, etc. because non-ST elevation MI, type 1, anticoagulation, antiplatelets that we give. But here we need to be very careful. And it is very common to see troponin rise with an intracranial event.
Thank you, sir. We have a protocol that we never started antiplatelet or anticoagulant in a patient with altered level of consciousness without doing brain imaging. And here I have thank you, sir. And I have a question here that troponin is about 20 times higher. So should we consider it as a raised troponin due to unknown etiology? And another, sir, another question about V4. There is an elevation in the end of the T wave, but only in V4.
The thing is, for the acute coronary syndrome diagnosis, one of the key components is chest pain, ischemic type chest pain. The clinical scenario should be there. It's not there. You can have to raise troponin in case of quite high raise in case of myocarditis, in case of CPR, in case of cardiac injury due to other cause. So that's what Hafiz Bhai was insisting. That before considering that one is SES, you have to have a clinical scenario suggesting that. And that could be either type 1 or type 2 MI. Here nothing is suggestive of either of that. But
so that's why I'm presenting this, because there's confusion.
Thank you, Dr. Kaniz. Thank you, Dr.
A couple of points important to add. If you are seeing the patient in the ICU after the diagnosis of intracranial hemorrhage, then you don't look at the EKG anymore, because even if it is true, it doesn't matter. There is no need, you cannot treat that. And
Yes,
this
sir.
can be a changes following the intracranial event. Now, if you see it before the intracranial hemorrhage diagnosis, then they will be dancing on your nerves. Oh, can you do something for this? In that case, I buy time. I buy time that you do echo, you find out what is the etiology of the augmentation, get a CT, exclude, because safety first. Now, 20 times of troponin high, it sounds bad that 20 times, but also if you look at the troponin plot and the differential diagnosis of troponin from the JACC paper, that troponin and the differential diagnosis of troponin, when the troponin is absolute value like 50, 100, then you differential falls below on very few. Myocarditis, acute coronary syndrome, MI. But if it is 1.6, it is not that high actually. But we created this sensitivity 0.02, different fifth generation even lower. So that's why it sounds like 20 times high. But 1.6 actually not that high. And many times with the adrenaline surge, we see this, adrenaline surge related injury and troponin rise.
Thank you, sir.
Okay. Thank you,
So
sir.
what about
Sir,
Kaniz?
I have
We have
have got-
Firoz bhai.
tall P wave, that means P pulmonally, right atrial.
I think, Dr. Govindo, I think the question is about MI. We are not discussing about P wave. You can discuss.
Can I make
Firoz bhai, I want to say another thing.
Sure.
When I was a student, one of our teacher who taught us that troponin I, if it is raised 6 to 7 times, then think about other differential diagnosis. But if it is raised more than 10 times, then it is always due to cardiac cause or MI.
I think
but there is no, I don't know whether he has any reference from book or anything. As my teachers are here, I want to learn from them.
I think we can follow the things what Professor Hassan Hafiz and Professor Wadud sir said. That
Clinical scenario.
troponin I increase is one of the criteria, but it should be supported by clinical features or ECG features or echo features, imaging features. If these three are not present, on that case, 1.4 troponin I, it may be due to non-MI causes, non-myocardial causes.
Firoz, can I make a comment, please?
Sir, just a minute. Thank you, Dr. Kaniz. We are short of time, so we'll listen to your next cases in another session. We'll go for the session of Dr. Rafiq sir.
Firoz.
Sir.
Just let me tell. Actually, there are two. That is Wadud Bhai and Khaled Mohsin want to make comment on this ECG. But before that, Kaniz Fatema.
Yes, sir.
Actually, your cases are very, very interesting, and we are very much really. I got too much interest, and you created a very good field of discussion. There is an endless discussion about your ECG. Really excellent. And because of the shortage of time, your next presentation I want to shift on the 2nd or 9th January. Are you ready? I think you will.
Inshallah, sir. If everything is okay.
No. We want to see your the rest of the ECG. We want to see your rest of the ECG. But actually, we have got that two presenters, Rafiq sir and Hafiz sir.
Okay.
So I think I will request you to stop your screen share, and your next session will be on the 2nd or 9th January. I'll let you know. Wadud bhai.
Okay. Thank you, sir.
Actually, Wadud bhai and Khaled Mohsin want to make comment on the last ECG.
Khaled bhai, please.
Okay. Now, on the other side of the coin, there is another entity which we find that there is a very significant precordial STT changes without any troponin rise. We call it a cerebral T associated with intracranial bleed. So we have to, this is the other extreme point. Here we see no ECG change, but the troponin is raised, and in cerebral T there is significant ECG change, but there is no troponin rise. So this is due to the autonomic disturbance caused by the intracranial bleed.
So Khaled, I just wanted to add, that is a typical pattern that comes in the exam. Giant T waves and the QT prolonged. That is really important to recognize. And I say this, if the EKG looks ugly and uglier, then it is less likely ischemic. So be careful about that. And then you may be confused with another entity that comes with the intracranial hemorrhage. You do the wall motion and you may be fooled. It may be wall motion anterior, but look careful. It could be Takasubu with the stress cardiomyopathy with intracranial hemorrhage. Bottom line is, try to find out an excuse not to cap these patients.
Hafiz, can troponin come from brain tissue?
Troponin does not come from brain tissue. The troponin I sensitive. This is
okay.
This is all injury from the myocardium.
Okay. Hafiz bhai, can it be Takasubu in this case as well? The cause of raised troponin?
Yeah, so it can be, and in a small number it is typical. But to prove that, we need ideally angiogram and apical ballooning syndrome. But if you don't do angiogram, there are plenty of data now that if you do echo and you particularly use definitive contrast, you can demonstrate that typical Takasubu pattern. Yeah. But my issue is that whatever it is not going to change the management.
Professor, please, we are waiting for you.
Well, I mean, for our audience that look, we have been through these confusing cases, and I'm going to have request Dr. Kaniz to stay with us. Interestingly, that I was planning to present these cases, and some cases we have no proof, and then when we can prove definitively, then it helps us reinforce our clinical diagnosis. So this is the first ECG I'm giving to the audience to answer. Give them 30 seconds, and then please put the poll up. There will be a series of ECG from this same patient. This is a 52-year-old male who was admitted with shortness of breath, hypertension, has borderline renal impairment, and this is the ECG. This is, please remember the date. This is August 27th, and I'm giving the heart rate is 102 beats per minute.
Remove pulled up.
There is atrial enlargement.
আর বলেন না
Atrial enlargement.
স্যার সুন্দর বলেছে।
Okay. Oh, this is excellent. I think a lot of respondent. I'm going to go over sinus tachycardia left enlargement is a partially correct answer. It is not normal ECG because there is tachycardia. So that makes it abnormal, number one. Number two, there is voltage criteria for left ventricular hypertrophy. Now the question is, number D, is it pericarditis? I mean, Wadud is the master of pericarditis, so he should comment on this. Will you diagnose pericarditis from this ECG?
No, because classical changes seen in AVR.
Yeah.
These are absent here. There would be PR segment elevation and ST segment depression. That's not there. And there is not widespread ST elevation, also absent.
Yes. So, sure. Even though I started with the discussion that we're going to talk about pericarditis, that does not mean the ECG will be pericarditis. So please remember that, that this is not pericarditis because it does not have the feature. There is some, in lead V2, V3, there is ST elevation that can be within the normal pattern. of ECG finding. But okay, but I think this is a very good answer. Okay, next ECG, same patient, 2 days later, unfortunately, patient develops chest pain, and now this is the ECG. Mild chest discomfort, heart rate is 81, and I have this ECG. Same patient, please remember, same patient, 52-year-old male. Now he has developed mild chest discomfort and has shortness of breath.
Was there chest pain? Was there chest pain?
Yes, sir.
It's MI.
Okay.
And anterolateral MI.
All right, sir. So, Hafiz. Hafiz is offline.
Look at AVR.
It seems pericarditis, sir.
Okay. So the question is, I want to discuss answer A. 50% said it is sinus rhythm with acute inferior and lateral myocardial infarction. Why are they wrong? And 35% said pericarditis. So it's a majority poll, right? It's like US election.
Yes, sir.
Okay,
The confusion regarding AVR, the ST depression in AVR can happen in case of LCX obstruction.
Yes.
In this patient has got lead to ST elevation lead to is more than 3. Mm-hmm. There is elevation in AVL and 1. Most likely it is an LCX obstruction. In LCX obstruction, the ST will be down in AVR.
Okay, so that's in their favor, right?
Sir,
Yes.
What will be against diagnosis 1?
Sir, can I say something?
Please.
The most interesting thing is that when the circumflex is involved, there will be ST elevation in lead 2 more than lead 3, which is present here.
Okay.
But the changes,
LC1.
the changes, these are not typical COVE pattern.
Okay. Yes.
That's the point against.
An ST depression. So possibilities are actually 1 and 4. Okay. We consider either one of them. With the clinical scenario, we have to decide.
Okay, fine. So I'm going to discuss normal ECG is out of question because this is not a normal ECG. We see ST elevation in place, whatever the cause is. Number 2, sinus rhythm with early polarization. Please remember that this is the same patient that we are discussing in a series. The patient did not have the same ECG before, and it's a little bit more than what we expected. So we still have left with number 1 and number 2. And the thing about this is that there is concave ST elevation. And the problem is that the patient is having chest pain. And I was consulted on this patient. And so we struggled. So what we did, I'm going to give you a second report, and I'm going to put the poll again. Now, we did an echocardiogram. Ejection fraction was 30 to 35%. There was no regional wall motion abnormality, and there was moderate pericardial effusion. So now let's see what the audience thinks after we found this. I mean, why am I giving it phase by phase? Because that's how we do it. I mean, if somebody came to me and the problem was that this patient was fairly sick patient, and the question was to take this patient to the catheterization laboratory would have been tricky. His white cell count was extremely elevated, and now ejection fraction is also the question. So this is on the 29th of August. So let's see what audience, if they change their mind now based on this echo finding.
Yes, sir. Sir,
Can it be acute myocarditis?
Okay, good. So now it's changing a little bit. So,
Yes.
so
Sir,
now,
The term should be myocarditis.
Okay. So now the issue is that because there is no regional wall motion abnormality, now the audience thinks that probably pericarditis chance is higher. Do you all agree with that thinking process?
Yes, sir.
Okay, fine. So I'm going to give same patient the next ECG is this. This is after 2 more days. Patient is still having chest pain. Now this is the ECG.
Now we are in trouble.
Yes. Until this time, I decided just to hold tight. Now this is the point that we were a little bit stuck, and we were, until this time, I avoided cardiac catheterization.
The game changer is junctional rhythm.
Yes, the junctional rhythm. That is the other problem part. That now we have junctional rhythm, and I was also worrying, is it 2-to-1 heart block or not? But there is no P wave at all.
Sir, again, this goes in favor of the myocarditis, sir.
Okay, let's see what the audience thinks. I mean, we should not talk first. Now, let's see. Okay. So, I mean, first of all, I'm going to look at number 1, sinus bradycardia. There is no P wave, so I cannot call it sinus bradycardia. Second, early repolarization pattern is not an option probably for this patient because this is an evolving change. So now we are all stuck with these answers. I'm going to put one more poll on the same patient. Let's see if it changes. Now I have the troponin. On the 27th was 1.1. Our level is 0.03. And then on that day it was 4.1. White cell count was 47.2, and the echo again showed moderate pericardial effusion, no wall motion abnormality. Now see if the diagnosis changes.
Poll, please.
Very interesting.
Well, it is interesting because our problem was that this patient has pericardial effusion and question of so that's interesting. Even with the elevated troponin, majority thought it is pericarditis. And okay, so at this point, I had no choice but to say, look, we have to do a cardiac catheterization on this patient. And we did that. And what it showed was basically 25% RCS strength, which is nothing, and all other coronaries are normal. And we thought that this was really a case of pericarditis. And I'm going to show 2 ECGs here. Look at this clue. This is the top ECGs from this patient. ST elevation, ST depression in AVR and V2, but V1 and not in V2. In the bottom is a patient with acute inferior MI. There is reciprocal ST depression in lead V1, V2, but not in AVR. I think, so if we look at, Wadud has been telling us a long time that ST elevation, PI depression, and ST depression in 1 AVR is a pretty good finding actually. And then wall motion abnormality was helpful. But of course, as in this case, I mean, that brings us to our cases of that Dr. Kaniz described that, look, in this case, we held off cardiac catheterization for 4 days. And then at the end, we say, look, we have to look at it. And then our final diagnosis was a pericarditis with possibly myopericarditis. It is causing elevation of ST segment, troponin. Any comment on this?
Sir, may I have a...
Sure.
Actually, doing a catheterization in a patient with pericarditis is also very hazardous. because if you the small amount of heparin we use during cardiac catheterization can lead to cardiac tamponade with aggravation of the pericardial effusion. So if you want to do the cardiac catheterization, we have to do it heparin free. That is very important.
Yeah, Khaled Mohsin is absolutely right. And that's why we held off. But the last ECG, with that junctional rhythm, with that ST elevation and troponin, we had to, and it was done, as you said, it was done without any heparin. So if we are planning to do a catheterization in this kind of patient, you have to be somebody who is very quick, fast, and can go in and out quickly without doing too many pictures. And that's what it was.
What about CT coronary angio?
CT angiogram?
Yeah. What would be the best option in this patient?
Well, I mean, that would have been an option. The problem is that this patient, at that point, heart rate was 43. And it was much quicker for us and to get a definitive diagnosis. And the couple of days earlier, maybe when the rate was slower, faster, and no junction, probably at that point, pericarditis. I don't, CT angio would have been a good option, but I don't know how presence of pericarditis would affect that. I mean, that's an option, of course. Are we done, or do you have time?
But the professor, if we do the CT angio, and if the patient actually have coronary artery disease, do the coronary procedure again.
Absolutely, absolutely. That was the problem that.
To the CT angio, you have to do the proper angio.
Yeah.
So WBC count was very high.
Yes, patient was septic also.
Yes, sir.
All
could be encountered by.
Background. Who is in the background? Okay. Please say.
As because there is WBC count is very high. What about the subprocalcitonin, sir? If it is septicemia, all these things can be correlated with the septicemia, sir.
Oh yes, definitely. I mean, no question. I mean, there is sepsis,
yes, sir.
And that could have contributed to this problem. That's why it was a very sick patient, and we struggled with this patient, and at the end we were forced to do the catheterization, especially the last ECG forced us to do the catheterization.
So, septicemic patient, sir?
What is it?
So one question is that there is no regional or global wall motion abnormalities, but there is ejection fraction is too low.
No.
Yeah.
How can you explain, sir?
Oh, yes. I mean, patient probably has non-ischemic cardiomyopathy. If you have non-ischemic cardiomyopathy, you will not have regional wall motion abnormality. So I think
the global wall motion abnormality.
Global wall motion, yes. But that was helpful to rule out coronary ischemia, acute ischemia, because with acute ischemia, we would have seen regional wall motion abnormality, which we did not in this case.
It was very good, sir.
And then how can you explain, sir, junctional brady in a case of only with myocarditis, sir?
Yeah, I don't know. I mean,
myocarditis can lead to junctional brady.
We don't know. I have never seen this, but if you think about pericarditis, that can precipitate atrial fibrillation. The question was that if myopericarditis have affected the sinus node in certain way, and that caused this thing, because we know we can get atrial fibrillation in case of patients with pericarditis.
Sir, assalamu alaikum. Sir, with that high WBC count, is doing cardiac cath pose any threat to the patient or increase any susceptibility to cardiac performance?
And after they have been giving antibiotic for at least 3 or 4 days.
Yeah, this patient was on antibiotic already. I mean, of course, that was the main reason that despite elevated troponin and ST elevation with chest pain, we did not do cath for 3-4 days. At the end, this junctional rhythm, possible heart block, forced us to do it. But that was helpful in ruling out the case. I mean, you cannot take this decision very lightly in catching this patient because it's a sick patient. So I'm going to do one more ECG. I'm going to skip this one. This is a patient that is scheduled for mitral valve replacement. And this is the ECG before the surgery.
Very nice.
That was good.
Very nice.
Very nice.
Alien RVA hypertrophy in mitral stenosis is easily common.
Okay, so this is very good. I like these answers. I mean, it's true that one person said sinus bradycardia, otherwise normal. And my answer to that person is, I mean, it is sinus rhythm, sinus bradycardia, which is true, but the QRS is wide. Once the QRS is wide, that is not normal ECG. So please remember that. Number two, sinus bradycardia with right bundle branch block is a good answer, but the question is there another beautiful girl standing next to this girl? Look at that also. And that beautiful girl is left anterior fascicular block.
Yes.
And there is one more thing, left atrial alignment. So I think this is very good. I think our session is helping, and I'm glad that all of you are participating in answering this question. Now, so this patient will go. Can you mute yourself, please? Can you mute? Yeah. Okay. And so the patient goes for mitral valve replacement, and on the day of mitral valve replacement, this is the ECG. November 2nd, it's just recently, post mitral valve replacement, this is the ECG.
Ah.
And this is a very important pertinent because once the patient gets surgery, the surgeons will call us to look at it, whether patient needs pacemaker or not. Do we need to do anything? Do we need to put it? And a good thing about post-surgery is that there is already a temporary pacemaker in place. They put epicardial wires and which they leave it for 3-4 days. So that's helpful. Okay.
What type of operation was there? Was it valvular dilatation or replacement?
No, mitral valve replacement. So majority said complete heart block.
Yes.
Sinus bradycardia, nobody said number A, which is very good. Morbid type 2 AV block, and only one person said Wenkeba AV block. So let's look at it. So what's happening? That the RR interval is irregular. If it were a complete heart block, I would have expected that the escape beat will be regular, which it is not. So even though the report says complete heart block, I did not think this was complete heart block. Morbid type 2 second degree is a possibility, but look at the PR interval. There is some change, this one. So I then measured the other intervals. The PP interval is, these are the P waves are good. This is, and this is what I thought is that this P wave blocked, this P wave conducted, this P wave blocked, this conducted here, this blocked. So over here, it is behaving like Wenkeba. over here is 2:1. Whether I call it Mobius 1 or Mobius 2, I cannot say that, but this is 2:1 AV block. So it is a little bit of complex mixture of, but definitely I don't think it is complete heart block. I think there is conduction. And the clue to conduction is presence of some irregular beat that it brought forward, and I thought this conducted to this one and this one. So this was on the 2nd, and this is the next day, on the 3rd, same patient.
Junctional rhythm. First degree block.
রিভু 20 সেকেন্ড দিয়ে তারপর 10 সেকেন্ডের জন্য পোজ দিও, তাহলে সবার দেখতে সুবিধা হবে।
Okay, sir.
First degree block.
Nice.
Good. So that's pretty good distribution. So, I mean, the question is what this is not. Even though I put atrial fibrillation, I don't think this is atrial fibrillation because the RR interval is very regular except here, and that is produced by the PVC. So this is not atrial fibrillation. If I look at in the beginning part of the tracing, I cannot see any P wave, then I can consider this as a junctional rhythm with right bundle branch block to PVC. However, the clue was that after the PVC, I can see the first degree AV block. And then if I follow it, I can see the P wave is here on the T wave, and it's sinus rhythm with first degree AV block, and that is the diagnosis. So this was on the 3rd. I don't want to make your life difficult, but next day, on the 4th, in the middle of the night, this is the ECG. Same patient. And it is important, this is not only academic discussion, because we have to make a decision whether, what do I do with this patient? And this is the ECG next day.
Very difficult.
While you are answering this question, I will request everybody that when you see interesting ECGs, you collect them, scan them, and write down the brief history. And that collection becomes helpful if you have some clinical history with the ECGs. Okay. For the first was, one person said sinus rhythm with first degree AV block. If you look at some of the P wave here, if you can see my pointer, it looks like first degree, but the next one changes. Next one changes. So the question is, junctional rhythm, nobody said junctional rhythm, which is fantastic, complete heart block versus Wenke by AV block. So let's look at the next ECG. So if you look at here, you can see the RR interval is perfectly regular, and then I have these P waves which have no relation to the QRS complex. You can see a P wave here. This is just the P wave beginning of the QRS complex. So now that tells us it's complete heart block. So please be carefully look at this, look at the P waves if you can find them, and you can find this, you can see the P waves here. And one P I imagined here, but this P wave is not imagination, because if you look at the T wave morphology here and versus over here is different. So that's the P wave. And also just before the QRS complex, there is a P wave, because in other places that's not present. So that's the P wave. And that is supported by other lead here. So this is complete heart block. Now, so next same day around in the morning, this is the ECG of the same patient. I'm going to finish, this will be the last ECG of the patient. And because after this, we decided not to follow the patient anymore.
Group beating.
Wadud already gave the clue, and I hope it is 100% correct answer. But the answer, whatever you think is right.
Oh.
Good.
Can it be AV dissociation with junctional rhythm?
Yes, it's a possibility. Okay. So nobody said sinus rhythm with sinus arrhythmia, which is great. One person said atrial fibrillation, and the answer to that, with atrial fibrillation, first of all, it will be totally irregular. It's not irregular. You can say group pattern. One group here, one group over here, one group there. Secondly, you can see P wave. So in favor of atrial fibrillation is irregularity. Against is the presence of P wave. So that takes it out. Second question is it complete heart block? If it was complete heart block, again, the escape beat will be regular, which it is not. There is a grouping in this that takes that probably complete heart block. So let's look at the timing. So I'm looking at, this is the P wave. This P wave conducted, this prolonged PR, the RR gets longer, longer PR, and then blocked. And again, short PR, long, and blocked. So this is a group beating. Group beating can happen in two places. One is common is sinus arrhythmia, other will be Wenckebach AV block. Let's look at the numbers of Wenckebach. If you look at the RR interval in Wenckebach, RR interval would get shorter. First one is long, second one is 680. Here 820 and 680. What's happening with the PR interval? 220, 480, 500. Why is the first RR longer? Because the first PR is the longest prolongation in typical Wenckebach. It's 480. From 220, it increased by 260 milliseconds. Next one is increased only by 20 milliseconds. That's why the next RR interval. So if you look at typical Wenckebach, the first RR interval will be longest, and then it will gradually get shorter. So this is typical Wenckebach phenomena. And this patient, conduction came back perfectly normal. We stopped following the patient. He went home. Thank you very much. And unless anybody else had any comment.
Fantastic.
Thank you, sir. Thank you very much.
Thank you, sir.
Jamil, want to say something?
No, sir. Excellent.
Excellent, sir.
I think, sir, after the lecture,
Today I'm a learner.
Questions are very good because it deals with real life scenario.
Exactly, sir.
And follow-up ECG of the same patient. Govindu.
Sir.
Acha.
We have got two more presentation, but it's 11.
No, Firoz. Actually, Hafiz Bhai will present it the next Saturday.
Okay, good. All right.
So, sir.
More than 11.5.
It is better to come and stop.
Sir, one ECG of Govindu, sir.
Kaniz, was it helpful, that ECG?
Yes, sir.
But you know, it's funny that I
it's a very complicated one.
Well, I held off doing catheterization for 4 days, but then at the end we were forced to do it. I mean, we had to have a definitive answer for this case.
But Kaniz Fatema actually presentation like you, sir. But that is several ECGs of the same patient, follow-up ECG.
Yes, that is good.
Thank
Sir,
you,
one more presentation, only one ECG from Dr. Govindu, sir.
Okay.
Govindu.
I like to show or Evo or Firoz Bhai.
No, you can share your screen.
I can also share, sir.
Okay.
The ECG. I think
Yes, Guru.
it's ready on my part. I can show it faster.
Show mode.
Okay. Dr. Govindo, you can read it.
A 64 years old female, diabetic, female, having recurrent palpitation and pre-syncope. And what are the ECG findings and what is the diagnosis or possibilities? And this is not the first ECG. On admission, ECG was PSVT, supraventricular, for example, supraventricular tachycardia. And then second ECG, sinus rhythm, sinus bradycardia, and this is the third ECG. So what are the interpretation?
Govindo.
Comments? Yes, sir.
Is this ECG after the adenosine?
No, sir. SBT spontaneously reverted.
This particular ECG, to me, it seems that the first two bits are normal sinus, followed by an probably it's a supraventricular ectopic bit. Again, compensatory pause followed by a normal bit, and then little bit irregular tachycardia for brief time in the lower panel rhythm strip. So it's here it developed atrial fibrillation.
Jamil Bhai, my question is, look at the fourth ECG beat. The PRN is not like that of the first two beats. First two beats, sinus beat.
Yeah.
But the fourth beat interval is very
short. It became short. That may be after compensatory pause, the conduction improves.
Is there any chance of sinus rhythm with atrial tachycardia followed by atrial fibrillation?
But in this ECG, there is no tachycardia before that atrial fibrillation. So it's difficult to say atrial tachycardia. And in that atrial tachycardia, the P wave should be a bit different from the normal sinus P waves. So there is no definite such type of abnormal P wave.
Please, Wadud sir, is there any comment?
Rafik sir, your comment please.
Well, I think Jamil pointed out very rightly. If you look at first bit sinus, second bit sinus brady, and then there is a supraventricular premature beat, and then there is a P wave. Even though the PR looks short, it's within range, 120 minutes. I think it is conducted. And then there is the actual premature beat. And there is a second one just after the QRS complex. So its first couple of beats, it goes into atypical atrial flutter, and then it degenerates into atrial fibrillation. So I think this is what's happening, and supported by the fact that this the irregular RR interval. When I see all this wavy baseline, I always think of artifact. But it is not artifact because the ECG before was pretty good. It's not a good quality ECG. So I think it, as Jamil said, that atrial premature beat followed by atrial flutter degenerating into fibrillation.
Sir, whether the rhythm strips, the rhythm strip on the bottom,
Yes. Mm-hmm.
as on the right side of the panel, the left side of the panel, the rhythm strip, that the QRS complex actually correlate with the QRS complex of the limb leads, but on the right side, not. So,
no, these are not simultaneous. This
continuous,
is not. It is not simultaneous. The first couple of beats, the first few beats are same as the 12 bleed. Rest of the rhythm strip is independent of the 12 bleed ECG.
Yes, sir.
Oh, sure.
So Govindo.
Okay. Next.
Govindo, what is your final diagnosis, Govindo?
Final diagnosis, I have
it was the
already
Govindo's
yes.
interpretation.
Underlying sinus rhythm with 3 sinus T wave. Already I put another ECG with drawing the arrow, but I cannot show here. And yellow arrow show what looks to be additional atrial activities. Some are blocked TSC. They are hard to tell if this is atrial flutter versus a first atrial tachycardia for subsequent 6 beats, after which atrial activity becomes much more variable without defined waves, as it looks like the rhythm deteriorate to atrial fibrillation. Sometimes this happens successive rapid atrial activity until an atrial wave in the atrial refractory period, which initiate atrial fibrillation. Thank you, sir.
Govindo, actually, message to our participant is that the explanation given by Rupik sir is the message to our participant. That is the atrial flutter degeneration to the atrial fibrillation. Your explanation is excellent, but message to our participant is that the answer given by Rupik sir is the message to our participant.
Yeah. But Govinda, your interpretation is excellent. I mean, you did exactly what we said. I mean, I just put it in the word that you already interpreted. So this is
exactly, sir. Actually, it was his presentation earlier.
Thank you, sir.
Thank you, Dr. Govindo. It was a nice one. I think we can wrap up now. I must thank Dr. Khaled Mohsin sir, Dr. Kaniz Fatema, and Dr. Govindo Pal. May I request Professor Abdul Wadud Chowdhury sir to wrap up the session?
Actually, it's our really a pleasure that all of our teachers, all of the present, those are present here. Jala sir is teacher to all of us, and he is here. He's always giving us encouragement and everything. That gives us a real pleasure. And today we have very good.
Thank you very much.
In practical life, we face dilemmas. We have to make decisions. We have to change those decisions according to the situation. And that flexibility and willingness to reinterpret and interpret again and again as per the new information available, that's the most important thing. What I tell my students is that our ego should never come before the well-being of the patients. So interpreting the ECG, sometimes we have to agree that I have been wrong. This is the most likely the proper diagnosis or proper interpretation. And we have to entertain the thought that there is always multiple possibilities according to the clinical scenario. And Rafik sir has beautifully shown those scenarios. And Kaniz has presented in the clinical practical life what problems we face. Thank you, everybody. And the panelists and everyone. Thank you. And good
I want to say something.
Yes, sir.
I want to say something.
Sir.
Jalal sir, I mean, this is for all of us to learn something. I mean, remember his presence here. It is possible that some of us know something more than he does. But it is because of him that we have reached here.
Yes.
The fact that he has been sitting here for 2 hours with us is a blessing for us. We should remember this. We should try to be like him and continuously learning, being present with us, even though it is possible that some of our panelist audience knows more than some of the things, more than him, but is still above all of us. Thank you.
Definitely.
Thank you very much.
Firoz.
Thank you very much.
Thank you, sir.
Firoz.
Sir.
Actually, next Saturday, dear participant, next Saturday, Rupik sir is always with us, and we are very much delighted to have some lectures from Rupik sir. And Chowdhury Hafizul Hasan will give show some ECG on the next Saturday. And finally, Rupik sir, Dr. Monarul Islam and Habiba Ferdowsi will present their cases in the next Saturday.
Yes, I think we should start with those. And then we'll do Hafiz, and then I'll do last.
Okay, sir. Firoz.
Thank you.
So we again asking you to present. And meanwhile, whenever you get interesting case scenario, please preserve those and share with us. And we can discuss together, we can learn together. And Khaled Bhai, it was a masterful presentation, I should say.
It was, I was over front of the electrophysiologists, Professor Atahar Ali and Professor Rafiq Ahmad. It was an audacity to present Brugada in front of them.
But you presented
Khaled Bhai, is she that lady we saw in the Square Hospital?
Yes, Jamil.
Yeah, okay.
I took your opinion as well.
Yes, sir. Yes.
Management.
I remember her.
Yeah.
I remember that case.
You helped me a lot in managing this patient.
Thank you. Thank you.
Thank you, sir. Thank you. Good night, everyone.
Bye-bye. Good night. Yes,
Thank you, sir.
Bibhu and your
Assalamu alaikum.
Bidhu.
Yes.
Thank you. Thank you. Again.
Yes, sir. Thank you.